Okay, so good morning, guys. Thanks for joining from the office. Can you guys see my screen?
Yeah.
Thank you. So, as always, we start our case discussions with a brief S-bar. So, situation. There's a para 1 who's attending at 36 weeks. She's contracting since about 2 o'clock in the afternoon. Her background is that she's a 28-year-old. She was low risk at booking. At 12 weeks, scan was normal, and 20-week scan, again, normal anatomy, normal Dopplers. A bit of further background. So she has a family history of platelet disorder. She has a bleeding tendency in her family, but herself, she's never had any coagulation issues. For that, we contacted hematology, and their advice was to give TXA at the beginning of her labor and to have a platelet pool on standby, TXA oral for the next 4 days. At 28 weeks, she presents once out of her normal routine for pelvic girdle pain, just prescribed some paracetamol, otherwise was uneventful. And she's coming to us in triage. This is now about just 5 minutes to 5. She's contracting. We'll do a VE. She's 3 centimeters dilated, mid position soft, presenting part is at -2. Membranes are still intact, and these are her observations. What's our recommendation? How would we like to manage this lady? Any takers? Come on, guys. Otherwise, I start calling names. Laura, would you like to tell us how would you like to manage this lady who's in triage at the moment? Liv, would you like to give it a go?
Yeah, I think Laura posted in the chat, but so
Okay.
she's.
Oh, sorry, I can't see the chat. Sorry.
That's fine. Sorry, how much did you say she was contracting?
She's contracting 3 and 10. Oh, sorry,
Okay.
Thank you, Laura. I didn't see the chat. Sorry, my mistake. Obstetric review, admit to antenatal ward as 36 weeks antenatal ward. Okay, and inform the neonatal unit. Why antenatal ward? Laura? So she's a para 1. She seems to be contracting well. She is preterm, and she's already starting to dilate. I would probably not put her on. Oh yeah, she's contracting intense. So we're going to put her on a CTG for the initial assessment as well. Yes, before we're deciding where she wants to go, how soon she needs to go. Okay. If this baby is completely normal, what would the CTG look like? So 36-weeker, low risk of booking. Where would we think the baseline would be?
Maybe around 150.
About 150. Is there a way to make that a bit more specific for this baby? go back and look at her antenatal assessments. So even though she'd never had a CTG so far, we have listened into this baby in the antenatal clinic. So we would see the numbers there, and that can give us a better idea about, okay, where to expect. But if we have no other information, 150 sounds like a good number for a 36-weeker. Yeah. Okay. What would we expect the variability to be?
Should be more than 5.
Should be normal. Yeah. Would I expect there to be cycling?
Yeah, it should. Yeah.
Yeah. Accelerations?
Well, she's contracting, so I'm not worried too much about the accelerations.
Okay. Decelerations?
Well, variables, on and off should be fine.
Yeah, she's contracting, so she can get port compression. That's expected. Okay. So looking through her antenatal notes, the beta heart rate has been about 148 to 150. So that also goes along with what you said, Eva. And this is her initial CTG. What do we think for that? Is that what you described? Is that what you expected?
Yeah, looks fine.
Pretty much. So, and she also seems to be contracting a little bit more than 3 in 10, I would say. So, again, that would mean definitely not the antenatal ward. This would be either our birth center or our labor ward. And given that she's 36 weeks, she would need the labor ward. But I would suggest that we get an obstetric review, as Laura was saying first. Yeah. So first question, I think we've answered that. Is this baby fit for labor? And I think the answer is yes. Do we all agree?
Yes.
Thank you. Okay. So registrar comes to review, and the recommendation is to stay on labor ward. IV access. Remember this. So for those who's just joining, this lady is a para 1. She's 36 weeks. She was low risk of booking, apart from that she has a family history of a bleeding tendency. And there's a family history of abnormal platelet functions. She herself has never had any bleeding, but the recommendation from the hematology team is to ensure IV access at labor, IV tranexamination at the beginning of labor, and tranexamic acid after the delivery. So the plan, the registry is to stay labor ward, get the IV access as planned, a full blood count and a group and save. IV TXA, IV benzodiazepine if she actually shrubs or is in active labor, and VE in 4 hours. Active management of third stage. She is quite uncomfortable, so she's already asking for an epidural. So I think we can safely assume that she's probably getting into active labor, given that she's also a para 1. Yes? So I'd probably start the benzodiazepine fairly soon. And this is her now on the labor ward, and she's sitting up for an epidural. What do we expect? What's the potential impact of an epidural on our CTG?
You might not get a good tracing of the CTG.
You might not get tracing while she's being cited. Is that what you mean?
Yeah.
Okay.
Yeah.
Well, we seem to be getting okay trace at the moment. We're monitoring that closely. What effect if we actually get a good tracing, what effect do you expect to see on that CTG? Or does an epidural have any effect on a CTG?
If the mother has a drop of her blood pressure, we may have a decel associated to that.
Yeah. Okay. So 1 in 50 ladies would get hypotension and potential reduced placental perfusion with an epidural. That goes up to that goes up 1 in 5 if this is a spinal. Okay. Ways around that? How do we manage that at Kingston?
So position and IV fluid.
So position, what do you mean by position? What position would you put the epidural in?
Lateral, left lateral.
So left lateral, that can work, avoiding that her legs are the most dependent part, yes. IV fluid, you mean fluid overload to start with?
Bolus,
Bolus,
500
okay.
mils over half an hour. Maybe you can continue a bit longer than the 500 mils.
Yeah, okay. Any other options?
If not responding, anesthetic can do ephedrine.
Yeah, so vasopressors, yeah. What do we actually do at Kingston out of all those?
Positional and IV fluids mainly, but we don't give the bolus before the epidural.
Actually, we can see that she's already sitting up for the epidural, so clearly we don't do the position. Okay, no, we actually do something. We do something. The only thing that we do, though, is we haven't mentioned it yet. So the options for half doses, yes, a staggering administration. Okay. Don't give the whole epidural at one go. Yeah, position, fluid, and epidural. Perfect. Okay. Any other effects that an epidural can have on our labor/CTG?
Is there something with temperature?
Anything else? So epidurals cause vasodilatation within the lower half of our body. That's why we become hypotensive. That's why the hypoperfusion. Okay. And with that, temperature can actually go up. So there is a slight rise in temperature, and that can be about 0.07 degrees per hour. So that is an ongoing thing once your epidural is in.
So,
okay, but not a huge amount
Ahmed
of increase. So as I was saying, at Kingston, we give staggering dose. Okay, and with that, we've managed to maintain the baseline as it is. We're now coming up to handover time and just about to do the consultant ward round. And this is the CTG when we're going in. Any recommendations or any change of plan?
No,
Okay.
she's due to be examined at 9.
Are we happy with the current plan? Shall we carry on?
Yeah.
I'm not loving. Can you hear me?
Yes.
Can anyone hear me? Yeah. Okay. Fine.
Okay. So the consultant ward round decides. Let's just repeat. Do the
I'm not
BE
sure Ahmed can
9
hear
as
you.
planned.
I don't think he can because I said something earlier and he ignored me.
We'll take it from there. CTG seems to be normal.
Hang on.
She seems to be contracting even more frequently now, but baby seems to be coping. Are we happy with that? Perrin?
Can you hear us, Ahmed? I'm not sure you can see the
I
chat.
can't hear you.
No.
Is it just my?
Yes, you need to put your. You can't hear us. Can you hear?
I can hear you now. Yes.
Yes. Sophie
That was
had a
very embarrassing.
comment.
Sorry.
Sophie had a comment about when you asked, "Are we happy with the CTG now?" And I think you couldn't hear that.
Okay. Sorry, I didn't hear you, Sophie. I thought it was just my cricket silence. What did Sophie say? I think she's left the chat now. Maybe.
Oh,
Yes,
she's back. Sophie Ahmed can hear you now.
Can you hear me now?
Yes, I can. Thank you. Sorry.
Oh wow. No, that's okay. It's not your. I don't think it's your fault. I think it was my computer. I was just going to say it just looks like she's contracting a lot.
She looks
Like,
like
it
she's
doesn't look like
contracting a
there's
lot.
much. Yeah, it doesn't look like there's much resting tone. Obviously, I wouldn't know that without palpating, but that would be my. I don't know how far you got in the conversation before I had to log out, but that would be something that I would be looking at. So I'd be palpating to check if there actually is resting tone between these contractions, because it looks tachysystole at the moment.
So there is resting tone between the contractions. It's just that she is contracting about 5, 6, and 10 now.
Lovely.
But so, any recommendations?
She's had a pen, didn't she? Because we're thinking she's preterm.
She's had her. She's had her pen. Yeah.
She's having, a lot of contractions. She's displaying sign of infection, but she's not. She's had a normal OBS as well.
She's
Temperature
displaying
is
signs of
normal.
infection.
I mean,
What do you mean?
she's got a lot of contractions going on for,
Yeah.
she's 36 weeks. She's got tachysystole, but the baseline of the baby is maintained to 140. So I'm happy with that. I would maybe want to know observations, but you seem to say that everything is going, as expected, meaning probably normal temperature and pulse and respirate.
Yes. Okay. So the assessment, literally half an hour later, this is 21:04. So abdominal palpation, she's 2/5 palpable. Query ROP. V, she's 7 centimeters dilated. Presenting part is at -2. Head is loosely applied though, but there's bulging membranes, and we're unable to determine the position by VE. But from the abdominal palpation, we think it's ROP.
Did we scan her, by the way? Sorry, just to confirm it's her head, because I thought we were scanning, preterm labors just to confirm presentation.
Not on the notes, but I'm hoping that given that they're feeling the head and I hope that it is cephalic, but I couldn't see that in the notes. No, I don't know. Okay.
What do you usually do as doctors? Would you usually scan at 36 weeks to confirm presentation?
If I'm happy that I can feel a head, then not necessarily.
Okay, thank you.
I can, yeah. Are we happy to carry on?
Yes.
Or any? Yeah. Okay. So plan is just carry on and keep observing. We hope this baby copes as much as it can. We get her into left lateral. We love biomechanics at Kingston, and we think she's ROP anyway. So we're trying to get this baby's head to turn and hopefully help with the malposition. And she's now getting more epidural top-ups. And we're pretty much at this for a while, up until 1:30 when she shrums. Are we still happy with the CTG?
Yes.
Cool. Okay. So we're now examining again. 2/5 palpable. This time we think it's LOT. We do a VE. She is fully dilated. Presenting part is at -1. There's no molding, but we're still not very certain about the positions, either ROP or LOA, one of the two. Bloodstained LICOR and FSE is applied just to help with monitoring the FH. Now, the moment FSE gets applied, we start STAN. So is this baby suitable for STAN? And this is the last hour of CTG. What do we think? Shall we go through our trees? Now, first of all, this is a preterm baby. Is this baby still suitable for STAN?
Yes, it is.
Yeah, so 36 plus 0, so yes. Actually, we're 36 plus 1 now. So it's more than 36 weeks. It is ruptured membranes. We are still first stage. Well, okay, actually, no, we're fully dilated now. Are we allowed to activate STAN? Sorry, Laura, say that again.
STAN is suitable in the passive second stage.
So we can put it in the passive second stage. Yes, yeah. Perfect. Okay. Note contraindications, and lady is consenting. Is the CTG normal? Okay, so do we have a baseline of 110 to 150? Yes. More than 50% of the baseline? Yes. So variability is normal in cycling. Perfect. So all happy to start ST analysis? We'll let it carry on. Okay.
I mean, I wouldn't start it if it looks like there's potentially detail when it went on. I probably would let the.
Sorry, say that again, Laura. I didn't hear that.
Sorry. It looks like when it went on, it looks like there might have been a deceleration. So I personally wouldn't have started Stan on that deceleration.
You mean she's just, I mean, here we're, can you see my pointer? Can you see my mouse moving? Yeah.
No,
So,
No, we can't see the point.
No, we can't actually for some reason.
okay, let me.
I think she's
Change
talking
it.
about where it goes, where the FSC
You
goes
mean
on.
here? Yeah.
Yeah.
So that's, this is where she's just having a VE. We're literally just having that change. We're going to get out of that position shortly. But before that, we have a completely stable baseline. It's a completely normal trace. There's no even decelerations despite all those contractions. So I personally don't have any objections to starting ST analysis. And we have gone down the trees and it seems to be okay. But well noted that there is a deceleration there. So I just need to keep an eye and make sure that I'm still happy. Remember, you're starting the scan appropriately. It's not just about the moment the FSE goes on. It's only the first half an hour of when the scan is actually working. Yes. So well spotted, Laura. Thank you. Does that make sense, guys? So looking through the next half an hour, we actually within 5 minutes get our first ST event. And then again, and then a third one. Is this a significant ST event? And this is our next tree. What do we think? Guys, can you still hear me?
Yes. The baby spending less than 50% of the time at the baseline.
Okay. So is the CTG normal? That's first question.
No.
No. Okay. And it's less than 50%. So we're going down the second arm now. So another no. Okay. Is there more than 10% rise in baseline? Sorry, is the baby spending less than 50%? Actually, no, sorry, intrauterine resuscitation. My mistake. Is the baby spending less than 50% of the time? Yes, and that's, so we actually need to make this baby better. So first thing first, I am the midwife in the room at the moment. What do I need to do?
Call for help.
Escalate, yeah. So coordinating midwife comes in within the next 5 minutes, and there's 3 more ST events. Okay. Now what?
Where is the baby? Has she been examined? And we call the doctors, including the P's.
So she had been, I mean, she was examined 15-20 minutes ago, not even 20 minutes ago, at 5 minutes to 2, when we made her fully dilated, presenting partlet -1 ROP. And that's when we put the FSD on. So
that's all we know so far.
That's all we know.
Okay.
We can examine her again if you want, but is that what we want?
Kind of depends. If the baby's just there, we need to have the baby, and that will stop the stress for the baby. Meaning, if that's why I'm asking, kind of, is the baby visible? And then
There's no vertex visible. No.
Okay, fine. So we need intrauterine resuscitation and or delivery.
Okay. Which one do you think we need?
Both.
Both.
Yes, she will need
Yeah,
an
we don't-
assessment.
We don't have to pick. We should always improve the environment for the baby while making moves to deliver.
So you can't do both. You can do one after the other then. You can
then
resuscitate
can we-
one
deliver, then deliver.
Well,
Yeah,
the midwife
Can
can
we
do
start-
one and the obstetrician can do the other. We can
Exactly.
work together.
Now, in this
She's-
scenario at the moment, there is no obstetrician. There's a coordinator
So
midwife.
then
We need to escalate.
So then you do, yeah, you
Yes, we do
escalate
need an
and then
obstetrician for
you
this.
improve
Okay.
the environment as best as you can, and then yeah, obstetric review ASAP.
So how do we improve the environment while we're looking for the obstetrician?
we have her on her side. To
Get
start
her on
with.
her side. Yes. So first of all, let's get her out of a position that may potentially be unhappy. Okay. It might be on her side, might be on her back, maybe on the other side, maybe even on all fours. Whatever position makes this baby stable. Yeah. Because things seems to be progressing quite quickly. Can we see that? Can we see variability has gone off fairly quickly? Yeah.
Yes.
Yeah.
So now registrar now in the room, and the registrar says the appropriate question is not, okay, I actually cannot rely on Stan because within the first 5 to 10 minutes when Stan was trying to make its baseline, this was inappropriate for Stan. So first question is actually wrong. This is, forget the ST events. This is decompensated gradually evolving hypoxia. How do I manage that? The head is still at -1.
You deliver.
Sorry, say that again, Laura. I didn't hear that.
You would deliver because this baby's something necessarily going on from it to go from a trace that was showing no signs of hypoxia or infection to suddenly not going from GA to GH and pressing, but gradually a decompensated. You consider examining, seeing where this baby is, can we deliver this baby safely in the room? Essentially, we're going straight to theatre.
Okay. Can you do anything else? Is there anything else that you can potentially do?
I mean, if she's pushing, I'd get her to stop pushing.
So she's not pushing.
Sure.
We're happy with that. Anna can eat terbutaline. Yes. Relax the contractions a bit more.
Yeah,
Okay.
but technically we can't give it without your say so.
Without my say so. What do you mean?
Well,
Yeah.
well, with an obstetric say so.
Yeah, of course. No, I understand. No,
So-
I understand that. I completely understand that. But
Technically.
yeah.
But yeah,
But
definitely.
I'm the
the number
locum
one
reg
thing
who
that's
doesn't
gonna-
know how we play it at Kingston. So what would you recommend to that reg?
I would say what we need to do is improve the environment for the baby. And what
So-
at the moment, what is stressing the baby is the contractions and the uterine activity. So what we need to do is remove that to reduce the amount of stress that the baby is experiencing.
So we're going to space out the contractions. So the decision was let's give terbutaline. And by the way, let's just deactivate Stan. It's not appropriate. So we're not going to rely on Stan anymore. Is that appropriate?
Yes. I mean, we know
Yes.
that this is decompensating, so it's not adding any value other than stress for the team. We know that as long as we remember that this baby needs to be delivered, we need to do something. As long as we remember that, then absolutely get rid of it, get rid of the Stan.
Especially because even if now the trace normalizes, the Stan has now set itself when baby was super stress decompensated. So even if I can rely on Stan later on, it's not the appropriate start for it. I need to restart it, even if I'm going to use it later. But the first thing, let's resuscitate this baby inside. And we give terbutaline. Terbutaline takes about 2 to 3 minutes to work. And we get her in a better position. So again, left lateral. And we can see that within a few minutes, we are now back to our stable baseline. We have a much better variability, decelerations, more appropriate responses. And she's now asking for an epidural top-up. If we're not delivering, let's just at least get some more pain relief. Is that appropriate?
I mean, yes, she needs pain relief. If she's in pain, we need to keep on top of the epidural top-up, but we also need to think of what impact that may have on the CTG, I guess, with a baby who has previously been stressed. So maybe minor changes may stress the baby further.
Yeah, true. So we've given the staggering dose. Let's see whether that is okay. We're only giving our half doses. We're not giving her the full top-up. And it seems to be holding. Yeah?
Yeah.
Okay. Now that we are stable again and steady, the question is, do we push? Do we wait? What do you think? It seems to be a busy night. The registrar literally threw turbitin at her and ran away. So the decision was, let's have the discussion before we start pushing. Yeah? Let's get the registrar to review before we start pushing.
Yes.
And
Yeah.
the registrar was actually busy in another room. So that's why they ran away.
Difficult. I don't know. I think so if this woman was 4 centimeters, we would probably be saying, actually, we need to do a cesarean section because this baby is completely decompensated.
But at the moment, it's not completely decompensated anymore.
Yeah, because we've corrected it, sort of, but the variability is still reduced. So we've reduced the stress, but it still has signs of decompensation because the variability is still reduced. So we would be, if what I'm trying to say is, if she was still in early stages of active labour, we would be moving for cesarean section. But because she's now fully dilated, we're thinking, oh, let's try and start pushing. I just feel like as soon as we start pushing, this baby is gonna
Decompensate again.
I mean, I would argue it's still decompensated. We've just given terbutaline to reduce some of the stress, but the moment she starts pushing, we're going to get the decelerations back. It's still a gradually evolving hypoxia that's decompensated. It just doesn't have any decels at the moment because we've removed the contractions. So I would say we need to either assess how close we are to the delivery, and I think an instrumental, if an instrumental is possible, would be the safest thing, personally.
Can I just ask if we could do a CTG assessment, because I'm not, if we're thinking of the context, I don't know, I'm not so unhappy about the trace. So I just want, to me, and correct me if I'm wrong, I would feel like...
I was going to ask for that. So Sophie, let's reassess the trace. Let's describe the trace. Where do you think your baseline is? Let's start there.
150.
150. Okay. Is that appropriate for her, given that she's also just had terbutaline?
Yes.
Yes, I guess so, yeah.
So I am going to just flip to my previous slides before the terbutaline. Yeah, so that's what the baby was when she was hyperstimulating. That's the reduced variability it can actually demonstrate. And we were about 160, 180, 170. And now after the terbutaline, we are back to 115. It looks pretty stable for me.
Yeah,
I see what you're saying. Are you happy with the baseline?
I'm happy with the baseline. My only concern is the variability.
Your only concern is the variability?
Yeah, because I mean, and obviously there's
variability,
but
there's no true accelerations on that. There is adequate responses though, and variability Variability is borderline at the moment. So I'm iffy variability, but our baseline has now come back to its normal and it's stable. Okay.
Yeah.
But I completely agree with you. If we start pushing now, this is very likely we're literally just stopped the decompensation. We're literally just stepped back into compensated phase. Does that make sense?
Yeah.
But if I start pushing now, I'm obviously going to make her decompensate again. And currently, my registrar is actually busy in another room. So that doesn't help the situation. Now, Anna, you were asking whether you can start ST analysis now if the baseline has settled. And the answer is yes, but just give her a little bit more time for the effect of the tubutin as well to go. Yeah, I wouldn't start it straight away. But at the moment, we are relying completely on physiology for the time being. And if there is the contractions are now spaced out, there's less risk of pushing for baby, possibly, yes. But once again, I need to make sure that I have a plan B just in case. So if she starts decompensating again, the answer would not be another tubutin, the answer would be deliver. In which case, I need to make sure my registrar is available. So we've decided to wait. That's the plan. Baby seems to be settling. Baby seems to be happy. We're just gonna give it a bit more time. There is no harm from waiting as long as baby is not decompensating. Do we agree?
Yes. And then, Hamid, would we restart jumping back on that previous question around now, like 3 or 5, when the baseline is gone back to 140, or you would wait even
back
further?
To 140. No, I could probably start that there. I could probably start ST analysis then. But they didn't want to make that decision. They said, well, we're just going to monitor via physiology unless things change, we're just going to carry on with physiological monitoring for now. They didn't decide to restart ST analysis, but they could have. You're correct. Now, the question is, the registrar is still busy. So how long would you wait for? It's now been
Where's the
over an hour.
consultant? I would be calling the consultant.
Where's the consultant at 3 o'clock in the morning? Is probably at home.
Yeah, so I would just call them.
Yeah, you can. That is an option.
Ahmed's like, no.
I mean, I'm here anyway. I don't mind.
Yeah, true. But if we've got multiple people that we're concerned about and the registrar can't come, as part of our escalation, we need to escalate. Therefore, we shouldn't be afraid to escalate up and above. Obviously, we should let the registrar know we're going to need to call the consultant, just inform them of what's going on. But I think that's the safest thing to do, because in a risk review, that's what we would say. We would say, actually, we should keep escalating up.
Perfect. I agree with that. But how long? The question is, how long are you going to wait? And remember, your consultant is half an hour away, at least, or half an hour away. So are you happy to wait for another half an hour while your consultant comes in?
How long has she been fully for?
We diagnosed fully at 5 minutes to 2, so an hour and 15 minutes. Okay, let's ask the question another way around. Are there any concerns for baby at the moment? Is anybody concerned about baby's status?
Not really the CTG, but we have a prem baby. So that would just be my only.
Okay, 36 in 1 day. So what's your concern about the prem baby? Baby seems to be stable at the moment. The bigger risk for baby is when we start pushing, because this baby has displayed signs of decompensation earlier. There is no signs of infection, although there was a bit of an irritable uterus earlier, which parent spotted. Well done, parent. But apart from that, at the moment, we seem to be not contracting too frequently. And if we can get the registrar to come out of the other room within the next 30 minutes, we should be okay to wait. Or if not, then we need to call the consultant in, and we should be okay to wait for the consultant to come in. There's nothing that we need to urgently do right now. Yeah? Does that make sense?
I guess it's variability that is what
Is a bit concerning now.
yes, it's concerning. I don't know for
is
anyone
your
else,
baseline-
but
Is
the
your
baseline's
baseline stable?
maintained. Yes.
I was hoping that somebody would pick that up, but yes, the baseline is still maintained though. Yeah, remember, gradually evolving hypoxia goes along that pathway. The variability will go off after the baseline goes up. Yeah, and there is
Yes.
no reason for us not to mess with that pathway, because, for instance, if she had been on labetalol, that can change. But at the moment, she's not on any treatment that can mess up my pathway. So I would expect the baseline to go up, which, if you notice there, it may actually be slowly going up. But we're just gonna make sure that this uterus is well rested and that she's in a good position, and we can potentially wake the baby up. Yes. So stimulate her, and variability gets better. So that's the thing that we may potentially do differently when I'm concerned about variability. Does that make sense? Because at a
Yes.
stable baseline, reduced variability may potentially be cycling. I wouldn't accept it if the baseline is higher, but if it's at the baseline again, then this may potentially just be cycling. How do I figure it out? Stimulate her abdomen, or VE again, or I mean, I wouldn't repeat VE so many times, but I would stimulate this baby and the variability improves. Yeah. Now we need to sort out our registrar. We finally get them out of the room, and they're here to review. What do we think about the trace? Has the decompensated gradual hypoxia resolved?
We have a stable baseline. We have an okay variability. We have baroreceptors decelerations. So yes, we are compensated now.
We're
That's-
compensated now. We're
Is
now
that
fully
right?
dilated for 2 hours. Yeah,
Yeah.
yeah, I agree. Okay. Now, the question that everybody has been asking was asking earlier. So let's reactivate Stan, and let's start pushing.
But I thought we don't
Whether it's-
reactivate when we are not when we are pushing. It's not passive anymore.
No, but we haven't started pushing yet. So reactivate
Okay.
Stan first, get your baseline, and then start pushing. Yeah.
Okay.
Remember, baseline takes 4 minutes,
Mm-hmm.
but reactivate Stan now potentially. And the moment we reactivate Stan, there's another ST event, and then it's. Can you see? So it's what it's drawing is what looks like a biphasic event. So within the first 5 minutes, we're getting Stan events again. We haven't even started pushing as yet. Okay. What do we think? Start pushing? No, start pushing. Is that long enough for STNs to be relied upon? That's the point. Good point. So not that one. That was too early for starting ST analysis. This may potentially be because they did not actually reset the ST. They started it, but they did not reset it. Okay, and that's another thing that we need to be focusing on. Because what I can't see here is a mark saying baseline determined. Sophie, can you see that? So once we have the baseline determined, there's like a mark. It tells you that the baseline has been established. It has not given you that, which means that even though they restarted STAN, appropriately restarted STAN, here they did not reset ST analysis. But they decided to go, you know what, we're just going to go with physiology. Let's just carry on. We have a stable baseline. We have the baroreceptor deceleration. It's compensated gradually evolving hypoxia. Hence, we are going to restart pushing. Not restart, actually, start pushing. Okay. And they just let her carry on for a bit longer to make sure that this baby is stable. Are we all happy with that?
Yes.
Okay. So at this time, rather than waiting from outside, registrar's literally there, poised with a kiwi in one hand and ready to just put it on in any situation. And she pushes 3 times, 4 times, and she has a baby. Now, what do we expect the outcome for that baby will be? And that's the magic of multiples.
The baby should have good ABGAS. The baby should, you know, it should be stoned a bit maybe at birth because there's this quite pronounced decel just before the birth, but the ABGAS should be good. There should not be long-lasting hypoxia. We have the peds on site anyway because she's 36 weeks, so if help is needed, they will be there. But I expect the baby will pick up very quickly, basically, if she's had a healthy pregnancy.
Do you think so? Why do you think the baby will come out stoned?
Just because of that acute, you know, decel just before the
This bit
baby is
there,
born,
yeah.
but that happens quite often, and but it might be very, very short, you know. You rub the baby and the baby will take a big cry straight away. That type of baby. So now fingers crossed you tell me and that's what's happened.
Okay. Anybody else have any other opinions? Do we agree with that? Anna's saying nobody's okay. Anna's saying that you think that the CTG at the end is improved. Yes. So Anna, answering that, the baby looks better. Yes, it is definitely better. This baby is now more awake. That's why I'm saying the ST event, I believe, is because even though they restarted ST analysis, they did not reset the ST analysis. So you need to reset the baseline again. The machine takes the assessment, puts it in its memory, and keeps that. Unless you tell it, just throw this away, start a new one, it won't do that. It will just keep it in memory. But Perrin, so you're right, this baby was absolutely fine, came out crying, okay, gases were also fine. It did show the episode of slight decompensation, so it was slightly higher base excess, but not unwell, and the gases were normal, with a slight bigger gap towards the end because of the longer deceleration just before delivery. Later on, the baby was admitted to the neonatal unit for breathing. It's a preterm baby still, but it was well and went home 3 days later with no signs of hypoxia, no signs of no problems. Any comments?
That was really well managed by the team.
I agree. I think it was well managed as well. Thank you, Anna. So thank you very much for joining, guys. I enjoyed that. I hope to see you again next Thursday, and hope you have a good day.